So, welcome everybody. We thought we'd have a short webinar again to update you about the trial. Hopefully, many of you know much of it already, but for those of you sort of still learning, still setting up your site, we go through some of the key points about the trial and give you a chance to answer questions. So what I'll probably do, just start by going through a few points around the trial and give you plenty of time to ask questions. So next slide, please. So if you remember, this is a trial. We've got three different interventions that we're studying, and got the diagnostic part of the trial and the fluid part of the trial, trials 1 and 2. And this is the larger part of the trial that is recruiting. Essentially, the eligibility criteria are adult patients that are admitted to the ICU due to suspected sepsis and expected to stay there 2 days. They should be receiving antibiotics already, according to whatever guidelines you have in place. And again, the fluid resuscitation, that early resuscitation should have taken place. We're not prescribing how much you give them, but you've corrected any fluid losses that and hypovolemia that they might present with at that time. And we, as I said, we want to recruit these patients early. We're going to optimize their fluid and antibiotic management. We need to do that early. So they need to be within that first 24 hours of their ICU admission. As we're going to talk about GM-CSF in a moment, that's the third trial, as it were. That's separate, but that 24 hours doesn't apply to that part of the trial. But for the fluid and diagnostic, they need to be within their first 24 hours. And we want patients in their first admission to ICU due to sepsis on that hospital admission. So if a patient happens to come in with, say, a traumatic brain injury, gone to the ward, and now they've developed pneumonia and come back to the ICU, they are eligible on that readmission, because the first admission was because of their head injury, for instance, in that case. We want to exclude people who are essentially dying of their underlying chronic disease. So if they've got end-stage disease and they're expected to die within the next 3 months for that, so essentially almost on the palliative pathway, these patients would be excluded. And similarly, if they're unlikely to survive the initial resuscitation, they're so sick, they're actually dying, again, it's unlikely that these interventions will affect them, so they would be excluded. We exclude extreme neutropenia, so that's defined less than 0.5 neutrophil count, due to chemotherapy or malignancy, but not due to sepsis. So if it's just overwhelming sepsis and they've become neutropenic, they're still eligible, but if it's due to they're immunosuppressed because of their treatment or underlying disease. And similarly, if people need a long course of antibiotics because of the type of infection, so we've said typically for more than 21 days, so an infective endocarditis, osteomyelitis, for instance, or an abscess, they may need long treatments, they would be excluded. And if people need fluid management that would generally follow a different guideline, so DKA, subarachnoid hemorrhage, diabetes insipidus, for instance, they would be excluded. And the lower weight to come in is at 40 kilos. Next slide. So that was for the larger part of the trial, the all-comers with sepsis. The third part of the trial, the GM-CSF part, is for a sicker group of patients and who are more likely to respond to immune stimulation than GM-CSF. So to be sicker, we say they have to be intubated and ventilated, or have multi-organ support, so vasopressors and renal replacement therapy. That would make them at a higher risk group for mortality. And then our marker of immunosuppression is that there are 2 absolute lymphocyte counts less than 1.2 on 2 consecutive calendar days. So that many people ask, well, what about monocyte HLA-DR as a marker of, for instance, immunosuppression? We agree that would be a good marker, except it's not available in all our hospitals, whereas the lymphocyte count is there. It's on every full blood count. So this persistent lymphopenia is a marker of immune suppression. So if you meet those criteria, these patients would be eligible for this part of the trial. And because this lymphopenia, this immune suppression may not be immediately apparent on ICU admission, you can recruit into this part of the trial up to 5 days after the ICU admission. So the exclusion criteria are anytime within the first 5 days where they've had these 2 consecutive values that are low on the lymphocyte count. And the other exclusion criteria, if they're already receiving the drug or GCSF, if they have a high white cell count above 50, again, we don't want to stimulate it any higher than that. If they're allergic to GM-CSF or it contains a yeast product, so if they're allergic to yeast, they would be excluded. Patients for this part of the SepTiC platform are excluded if they're pregnant or they're breastfeeding. And that does need to be tested with a pregnancy test. So we don't want to include give GM-CSF to pregnant patients. Just to say, for the first 2 trials, the fluid antibiotics, that's fine. Pregnancy is not an exclusion to those parts, but only to the GM-CSF part. If the patient has an active hematological malignancy, and we're defining that as treated for that malignancy within the last 5 years, or if they've had a bone marrow or solid organ transplant, they're excluded. And there's an upper weight limit here, basically because we wouldn't have given them enough drug of 125 kilos. So those are the inclusion exclusion criteria. So what happens in the trial? Well, let's explain them 3 bits separately. Trial 1, the diagnostic part, where we're trying to optimize antibiotics. You get randomized, the patient gets randomized either to standard care or PCR and a procalcitonin test. The PCR is sent to a central lab at Imperial, and the PCT is done locally at your site. If you follow the standard antibiotic management, what happens is you prescribe your antibiotics according to your local policy, use all your standard microbiology samplings, discuss with micro on a daily basis, short course of antibiotic, standard sort of care. If the patient's randomized into the other arm, as I said, you send the PCR test to us centrally to the Imperial labs. And what that PCR does is, first of all, detects whether a PCR product from a pathogen is present or not. And you should get that result back the day we receive the sample. So we'll run it. If it comes early enough in the day, we run that and tell you the PCR was positive or negative. If that result is negative, i.e. no product, oops, go back one. Sorry, thanks. If the PCR is negative, that means that no organism was detected in that result. So no pathogen detected. And what we're asking is look at the procalcitonin results, and it will be 2 results. And if both are negative or there's been a big drop, an 80% drop, that would suggest that the patient, they maybe haven't got infection. No organisms have been detected on the PCR. The procalcitonin is negative. The body suggests there isn't an inflammatory response to that infection. And if you've got no other objective criteria of pathogens, so you haven't grown anything from routine microbiology sampling, or if you've seen, for instance, I would say objective criteria might be white cells on a lumbar puncture, purpuric rash. These are, I think, objective signs where no one's going to stop the antibiotics as a sign of infection. But if there's no sign of infection, you stop the antibiotics. If the procalcitonin result, on the other hand, is positive, that suggests that maybe there is an infection and even the PCR hasn't detected, so you just carry on the antibiotics. If the PCR has come back as positive, then as soon as we see it positive in the lab, we'll let you know, and we say, carry on your antibiotics, and we will give you more information about that PCR the next day once it's been for sequencing. And we'll give you a result back that if it's a pathogen that's on one of the recognized sort of pathogens likely to cause sepsis, you should focus your antibiotics to target that organism. If it's a pathogen that is not listed on that report, it could be a contaminant. We will let you know what the organism is and say, well, you decide whether you want to change the antibiotics or not. Essentially, those sort of wording is how it's said. And sometimes, actually, when we send the PCR product off, we've realized that actually you can may not actually detect an organism, and we will then tell you that no pathogen was detected, and you look at the procalcitonin results as if the PCR was negative. Next slide, please. Okay. So that's around the PCR, where you can ask questions in a minute, but I think it's easy if I go through all three parts first. With the fluid, if the patient is randomized into the conservative fluid management, we've got an algorithm that guides what you should do. No routine maintenance of IV fluids, and give only further IV fluid boluses if the patient meets the objective criteria of hypovolemia. So that's a skin mottling beyond the area of the kneecap. You're struggling to keep the blood pressure up without going up without your noradrenaline, for instance, or if your lactate is above 3, or if there's oliguria on day 1. So we're only using the oliguria criteria on day 1. On day 2, 3, 4, 5, we don't think oliguria necessarily represents hypovolemia. Urine outputs go up and down. So what we want to avoid is giving these patients fluid boluses just because the urine output's a little bit low. So only give the fluid boluses if they're these objective criteria. Give a bolus, assess whether it's improving, and give another one if need be. On this days 2 to 5, what we're asking you to do is consider whether you may be able to actually start taking fluid off, deresuscitating. So what we say there is if the patient is cardiovascularly stable, defined as noradrenaline at less than 0.2 mics per kilo per minute, and no signs of hypovolemia, or they're even hypovolemic, which is edema in more than one place, and that includes on the chest x-ray, and they've got a positive fluid balance, then start giving them diuretics. And again, you can see the diuretics there: indapamide, a frusemide bolus, followed by a frusemide infusion, aiming for a liter negative each day, and continue that for days 2 to 5. In comparison, in the standard care arm, you give your normal fluid boluses as you feel appropriate. You can give maintenance fluid if you want it, standard drug dilutions. If you need to give a diuretic for a sort of standard treatment, you can, but not sort of early, and not trying to actively deresuscitate in those early parts of the stay. And next slide. And the GM-CSF part, as I said, it's in that smaller, sicker group of patients, slightly immunosuppressed. They get randomized to a blinded infusion of GM-CSF, which is either, if they're less than 50 kilos, just one vial, 250 mics given once a day subcutaneously for 8 days, or if it's patients between 50 and 125 kilos, which would clearly be the majority of patients, they get 500 mics, which is 2 vials subcut once a day for 8 days. The kits will be delivered to pharmacy, and they will get 8 boxes initially. It may be, if you want, because you can't, most hospitals can't dispense research drugs at the weekend, for instance, you may best probably to keep the 4 kits up on the ICU in a fridge there. And there'll be these 4 boxes, obviously 2 of each. So you, the randomization system will allocate a number. You go and pick up one of those boxes when a patient is allocated the right number, and in there is all the drugs they will need for that one patient for that 8 days. Although the powder needs to be kept in the fridge for long-term storage, it's absolutely fine to keep it at the bed space for the 8 days while they're being treated. We'll give a handling, IMP handling manual, so you know how to deal with all of that. And just to add, we do need an unblinded pharmacist at site to manage all of this. They will need to be on the delegation log to manage the overall IMP assessment.
So moving on to consent. So if a patient has capacity, then obviously take informed consent from the patient. And in the middle here, if the patient does not have capacity, we have options of a personal legal representative, so that's a family member, or a professional legal representative if the family member is not available. And the professional legal representative is an independent doctor, so that's someone that's not listed on the delegation log. And if the patient, when the patient regains capacity, we ask that you obtain retrospective consent. So we always need to ensure that the patient or family are aware of the patient's participation before they're discharged, or soon after. So as soon as possible, we wish to obtain retro consent. We do have an option where we can obtain retro consent via the telephone using verbal consent. if the patient is discharged before you speak to them and they have capacity. Little bit about sample collections. So we are collecting samples in this trial. So we've got a little flow chart here to explain when we collect samples. So when a patient is randomized, we collect 3 samples from the patient at baseline. So a baseline serum, baseline DNA, and a baseline RNA. If the patient is randomized to the diagnostic PCR, an additional 10 ml EDTA sample is taken. And if a patient is randomized to the GM-CSF, there are a few extra samples. So an extra PAX gene taken at baseline, and then 1 taken at day 3 and day 5. In terms of posting samples, so we will provide you with some sample packs. Each pack will be prepared 1 per patient. And depending on what intervention the patient is randomized to, you can then collect extra samples. So the 10 ml EDTA if randomized to the PCR, for example. All the samples will be sent via Royal Mail safe boxes. So these should be sent on the same day via a post box or hospital mail room. And depending on how frequently the post is collected at your site, we advise dropping the samples into a late collection post box. So this is what the priority post boxes used to be called. If the samples are taken late at night, they can be stored in the fridge until the next day. So I believe most of you have experience of using these safe boxes. A little bit about training. So we have specific study training depending on the role. So we have a staff training log for most training. So that's the PI, nurse who are consenting and completing follow-up questionnaires. We then have some specific open clinical training. So that's our database. So we have PI training, those that are just entering data, and those that are just randomizing. We also have sealed envelope training for the unblinded pharmacist. So each unblinded pharmacist at site will gain access to the sealed envelope system, which is part of the database that will be unblinded. And then we also have eligibility training. So we have the option to include those that are assessing eligibility of the patient. They do need to be listed on the delegation log, but they don't need full GCP training. So we do have specific eligibility training, which covers some elements of GCP, but it's just a slide deck that the clinicians need to review before assessing eligibility. And then moving on to next steps. So on the left here, for sites that are interested in joining SepTiC, we have a feasibility questionnaire, and then we will contact you and arrange an evaluation call. And then proceed with site selection. And on the right here, those that are ready for, that have been selected and are progressing to site setup, we'll send you the local information pack when you're ready. We have the site agreement, so the contract, and then once it's signed, we'll arrange SIVs and move forward with site setup. So we have a very helpful website. So we pop all our documentation on the website. So if you log on, we've got some images here. We have a tab for site staff. So we have all our study manuals and documents on there. And then we've got a frequently asked questions tab with all our FAQs on there. So they're segregated in sections. So we've got a general section and then each section for each trial in SepTiC. And do provide us with any feedback, or if you find that it's difficult to navigate the site, or if there's something that you think would be helpful to pop on there, do let us know. And then just some contact us. So this is our email address and website address and Twitter. And we do have some really helpful videos on YouTube about how to randomize, about the trial, and yes, just some helpful bites.